Hi, everyone. Welcome to a comprehensive review of dermatopathology, episode 10. Today, we're going to cover pigmented lesions. So, to start from the very basics, let's review what a melanocyte looks like. Your melanocytes sit along your DEJ, right, your basal layer, and they have these dendritic processes that deliver melanin to your keratinocytes. And so everyone, no matter what skin tone you are, has the same number of melanocytes for the most part in the beginning. And then what we differ in is the amount of melanin that we have in our keratinocytes. So what does this look like in the skin? Well, here you have your basal keratinocytes and you see your melanin sits on top almost like an umbrella. That's what protects you from the sun. And then your melanocytes are these little round guys at the bottom. And they say, in a 3D sense of the skin, a melanocyte's dendritic processes touch maybe 32 or so keratinocytes. But when we're looking at the skin 2D, that number is quite different. On average, on non-sun damaged skin, you would see about 1 melanocyte per 7 keratinocytes on average, I would say. And then in sun damaged skin, that could be 1 to every 3 or so, or 1 to every 2. You start getting worried when it's, every single one, because then you're becoming confluent. And then in our darker areas, for example, our axilla, our groin, kind of these nether regions, you have more melanocytes as well. So just to point out, all the little melanocytes, you see their cytoplasm is different, their shape is different than the basal layer of the keratinocyte. So this is what our melanocytes look like. Now, sometimes you get a little bit of an artifact. So in this specimen, we have an artifact, and a lot of you guys learn to identify halos to find melanocytes, but there's a difference between a melanocytic halo. This is a melanocytic halo. What happens is the cell shrivels in away from the cell wall. So what happens is you see these little strands. That's the cytoplasm of the cell being torn away from the cell wall. In contrast, keratinocytes can have a halo also. So here you have a nucleus, and now you can see there's a halo around your nucleus, but your cytoplasm is still attached to your cell wall, which you can see here as your desmosome. So your cell wall and your cytoplasm is intact here, halo around the nucleus, here halo around the cytoplasm, which is being torn away from the cell wall. Okay, so not all white spots mean melanocytes. So what are we going to cover in this chapter? We're going to cover pigmented lesions without a melanocytic proliferation. So freckles, cafe au laits, Becker-Nevi, melasma, solar lentigos, right? And then benign melanocytic proliferations, which include a simple lentigo, a nevus, you can have junctional compound intradermal, Mongolian spots, or, things in the melanocytosis category, and then blue nevus, Spitz nevus. And then you have simulators of melanoma, so recurrent nevi. We're going to talk a little bit about the dysplastic nevus mess that's out there, and special site nevi, and then we will look at some malignant melanocytic proliferations, otherwise known as melanomas. So back as a review, here's our epidermis, our pigmented keratinocytes, and our melanocytes. And here is a solar lentigo. So they talk about little dirty socks. Sometimes you don't have perfectly dirty socks, but you have a little bit of an epithelial proliferation. And what's most important to know about a solar lentigo, that it is pigmented keratinocytes. So, at baseline, a person who has this amount of sun damage, see all the gray solar elastosis, they usually would not be this color skin. This would imply maybe a type 4, 5, or 6 skin color. But their keratinocytes are this pigmented because this is a solar lentigo. So this disconnect kind of tells you you're looking at a pigmented lesion rather than someone's baseline skin color. And so you have increased pigment in these keratinocytes that sometimes form these little, projections downward. But the important thing to note is these are all keratinocytes. You do not have an increased number of melanocytes. What is a nevus? Well, we specify that we're talking about melanocytic nevi because a nevus is any congenital or hereditary anomaly. So You can have nevi of the epidermis or its adnexa, so epidermal nevus or nevus sebaceous. Blood vessels would be a nevus flammeus. Some mesodermal elements might be a nevus lipomatosis or melanocytes, and that's why we talk about a melanocytic nevus to be specific. So when we talk about good melanocytic processes versus bad melanocytic processes, there's some features that we look at that will help us decide if something is good or bad. So symmetry is good, asymmetry is bad. Small is generally good, large is generally bad. Well circumscribed, that means we can see very clearly where the lesion starts and where it stops. It doesn't kind of trickle off into the edges. Poor circumscription is bad. We like melanocytes to be nested at the base of the reedy ridges. What we don't like is runs of single melanocytes that are not confined to the base of the reedy ridges, meaning they run up into your interpapillary plates. And if your eyes just glazed over, I'll explain what I mean later. We like melanocytes to be monomorphous, meaning they all look like each other. They might be plump, they might be spindled, they might be, small and round, but they should look like each other. We don't like pleomorphic melanocytes, melanocytes that don't look like each other. And most importantly, we do not like to see melanocytes above the dermoepidermal junction. There are instances where we can see it under normal circumstances, such as a Spitz nevus or a very irritated nevus. If you rub your forearm really hard and do a biopsy, you might see a few melanocytes above the DEJ. But outside of that context, we do not want to see melanocytes above the DEJ. So here is a lentiginous nevus. So what we saw earlier was a solar lentigo where we had a smooth basement membrane and pigmented keratinocytes. But here, I hope you can appreciate you have these little round melanocytes lining around the edges. And if you notice, they spare the interpapillary plate. So just the tips of the reedy ridges have this lentiginous proliferation of melanocytes. And if you have at least 3 in a row, you generally have a melanocytic proliferation, and certainly if you have a little nest like you do here. So all of these melanocytes are small, round, monomorphous. They spare the interpapillary plates, and they stay mostly at the tips of the reedy ridges. And this thing is not very large if I showed you the whole thing. So it's a benign nevus. So here's up close, so you can see. Sometimes I call it a scalloped edge. Sometimes I call it a beaded, like pearl necklace edge, but you see these round cells around the edge. This is just a side by side. This was a solar lentigo. You see, a basement membrane is going to be smooth. Keratinocytes have a basement membrane that connects them to the dermis via the hemidesmosome. Whereas here, you see, you don't have that. You have this pearl necklace. So this is a lentiginous nevus, or if it's just a few less melanocytes, it's a simple lentigo, right? A simple lentigo kind of is on a continuum with a lentiginous nevus, whereas a solar lentigo is keratinocyte pigment. All right, what is the most prototypical nevus we talk about? Well, a banal or banal, whatever you say, nevus is these round nests of melanocytes. So everyone can see these cells with these more gray cytoplasm and pigment. They round nest because they're round cells, and they sit at the tips of the reedy ridges. They don't go up here into the interpapillary plates. You see those are pretty clean up in there. Here's up closer. So your round little nest, round little nest, round little nest. Nothing up above here. You have your nice desmosomes, your lattice work of epithelial cells. Nothing is disturbed up there. Here's a more congenital pattern of nevus. So you have some single melanocytes up in the epidermis, and then you have a lot of melanocytes down in the dermis. And we use this word maturation for dermal melanocytes. Well, what does maturation mean? Maturation means that up higher in the dermis, you have these plumper melanocytes. Here they have more cytoplasm and they're more nested, and as they descend downward they become more single. So you see a lot of little single cells, and they become smaller. So now you're only seeing the nucleus, you're not seeing that plump pink cytoplasm. So that is a good maturation pattern. When we see nevoid melanomas, we see similar cells on top and similar cells on bottom with atypia, and that kind of triggers you that you don't see this maturation pattern to look closely so you don't miss a nevoid melanoma. Here's another one. Here's an intradermal nevus. And these melanocytes are also maturing, but this is sort of another change that we point out. Here they're nested round melanocytes. And here they actually almost look nerve-like. They're kind of spindled, and this is a change that we can see in older nevi, neurotized nevi. And here's just comparison to a real nerve to show you how close they look. But usually there's some nests on top that kind of tell you you're looking at a nevus that's neurotized rather than a neuroma. Here's just another example of benign round melanocytes that are nested, and then as they descend, they get smaller with less cytoplasm, okay? So those are benign, really banal nevi. So what are we talking about when we talk about these quote unquote dysplastic nevi? And I put this in quotes because there is a lot of problems with the naming and the use of this word. And we'll talk a little bit about the background and how I perceive it. And certainly in every institution, people perceive it differently, which is part of the problem. So back in 1978, Wallace Clark described BK moles. There's these brothers, and they had many, many, many atypical appearing nevi, and they went on to develop many melanomas. And this was named the Dysplastic nevus syndrome. And he biopsied some of these very large atypical looking nevi, and he described their characteristics. They were all greater than 10 millimeters, so they were large. They were multicolored, very atypical looking, and in their histopathologic description, they had atypical melanocytes. They had a lot of dermal fibroplasia and a lymphocytic infiltrate, among other features that he described. Well, the problem is that there is a subset of nevi that have architecture that is similar to this, but were always previously just referred to as benign nevi. So, and their architecture differs a little than those banal nevi I just showed you. So these were reclassified based on an architectural pattern that were shared with these very atypical nevi. So bridging reedy ridges because of this dermal fibroplasia, and then shouldering, which we'll talk about, where your junctional component extends at least 3 reedy ridges past your dermal component, and it just sort of, you know, is talking about a more wide, broad nevus rather than these kind of more vertically oriented nevi. And you may or may not have cytologic atypia. So what happened is all of these previously benign nevi were now reclassified as Clark's or dysplastic nevi because they shared this architecture, whether or not they had atypia. And the other problem is that almost all acquired nevi, all the flat dark nevi that you get after childhood have this architecture. So in time, we looked at these studies and they showed that these nevi were common and they were not precursors to melanoma. These that shared architecture but were not necessarily very atypical or large. And they were just likely a marker of increased risk. We know that if you have nevi with this architecture and you have greater than 50 or greater than 100, you have slightly increased risk of melanoma, not necessarily in these lesions, but in your lifetime, because you sort of have a melanocyte problem. The problem is the name dysplastic nevus has stuck, even though a lot of these are just these benign nevi. Anything with this architecture has now come to be referred to as dysplastic nevus, so it confuses people. Other names that have been used are nevus with architectural disorder or Clark's nevus, but even Clark himself was kind of dismissing this process because he didn't think that these benign lesions that didn't fit all these atypical criteria should be lumped into this category. So what are we talking about? That's kind of an outline that you can go back and reference, but we're talking about these types of nevi. So this lesion is not large, probably 4 millimeters, and it's well circumscribed. So I can see that it starts here. I can see that it stops here. It's fairly symmetrical. When we zoom in, we'll see there's no melanocytes above the DEJ. There's no pleomorphism of the melanocytes. So nothing about this has those features of good or bad that I talked about earlier in the lecture. But what they do have is an architecture that shares features with those atypical ones that Clark was describing, which today would probably be referred to as a dysplastic nevus with severe atypia, okay? So the architecture that they shared was bridging of the reedy ridges, all right? That means that rather than those round melanocyte nests that I showed you with the banal nevus, now these melanocytes are oriented a little bit more lentiginously, meaning they line up next to each other, and they're kind of bridging the reedy ridges. And there's this lamellar fibroplasia. So you can see this kind of dark halo around this. There's a bit of fibrosis, tissue reaction, a little bit of inflammation, pigment dropout. There's tissue reaction to this lesion because your body sometimes doesn't think it should be there. And then you may or may not have cytologic atypia. So this is kind of what was suddenly in that time referred to as a dysplastic nevus. So coming in closer, you can see here we have the bridging reedy, right? You have these reedy ridges, and now you have all these melanocytes, and they're kind of reaching across and holding hands. Lamellar fibroplasia, that's this red fibrosis that surrounds it. Here again, you can see that the melanocytes, rather than individual round nests, they're kind of more lined up around in addition to being nested and kind of bridging. And this lesion is a little bit irritated. You can see pigment all the way up into your cornified layer, and you can see a little bit of pigment drop out around your blood vessels here as melanophages. Here is the shoulder. Shoulder means that you have 3 reedy ridges at least of a junctional component that extends past your dermal component. So it kind of means you have a broad, flat lesion with just a few melanocytes in the dermis, okay? That's a shoulder. That obviously only applies if you have a compound lesion. If you have a completely junctional lesion, then a shoulder does not apply. So as a side to side, this was our banal nevus with these round nests at the tips of the reedy. And this is this acquired nevus, okay? This more lentiginous acquired pattern of nevus where it's got this bridging reedy and a little bit of this tissue reaction, okay? Here's another example. This one's got a little bit of a congenital look in the dermis, but the epidermis has this fibrosis, and you see how it's lentiginous and bridging. So this would also qualify under this kind of what was originally put into this dysplastic category because it shared the architecture. And here is just like a purely lentiginous nevus. It's like the one that I showed earlier, but now your reedy are bridging and you have a little bit of this fibrosis. So even though it's a completely benign lentiginous nevus, some people started calling these dysplastic nevi. Now, all of these that are completely benign with the well-circumscribed characteristic, the symmetry, no cells above the DEJ, these were, when people started calling them dysplastic nevi, they would say they were dysplastic nevi with mild atypia. And then they started doing this grading with the mild, moderate, severe. And as a convention, a lot of dermatologists would say, okay, dysplastic nevus with mild atypia, that means nothing. But if you actually stop and think about it, if you show a patient a report that something is dysplastic with mild atypia, it's not the most reassuring sounding diagnosis. So it's just a convention. If you really think about it, these are the most common acquired pattern of nevus. They are common and benign. We probably shouldn't perpetuate that confusing language. So just as a review, what constitutes atypia? It's asymmetry, poor circumscription, cytologic atypia, melanocytes above the DEJ, areas where single melanocytes predominate over nested ones, and large size of the lesion, right? So none of these things include those architectural features. When you have this architectural feature with these atypical features, that was the true Clark's nevus. All right, so this is what he was talking about. This already, from far away as a silhouette, looks worse than that first one I showed you. First of all, the person's really sun damaged. And now you have bridging reedy, but from side to side, it's kind of hard to see where this lesion starts and stops. It's a little bit bigger. Your reedy kind of go in different directions. And then when you go in closer, your melanocytes are, you know, kind of atypical looking, and you have various melanocytes above the DEJ. So here, look, your melanocytes are in your inner papillary plates where I said you don't like to see them. You can see them above the DEJ, which is a little bit hard to see because we have this haloing around the keratinocytes. See more atypical melanocytes in your inner papillary plates. And now your redi are kind of shaped funny because your melanocytes are shaped a little bit funny. So this one has atypia, but it shares that architecture of the bridging redi and lamellar fibroplasia. This is something that we might call a severely atypical dysplastic nevus. And those are truly dysplastic. The word dysplastic implies pre-malignant, right? And so these actually are probably an intermediate lesion on their way to melanoma. So there's a name controversy because currently still in many practices, the term dysplastic encompasses these two types of nevi. One, which is wholly benign, right? It's the one deemed the mild, which we're supposed to disregard that term. And then the other one that has this uncertain malignant potential. And, you know, many papers were written back in the day about this controversy, and people were super confused, and people were also talking about different things. One group, you know, in Boston might have been talking because they really wanted to decide what criteria would make something mild versus moderate versus severe. And then, you know, the other side in New York with Ackerman were complaining that, you know, they were including two different types of nevi, and one was wholly benign and shouldn't even be in this category. So they're actually arguing about different aspects of this. And there was no consensus on what criteria justifies the name. So we're kind of all over the place. Because everyone was all over the place in the 90s, there was a consensus conference where they were like, let's propose a new name. Instead of calling it dysplastic, because that's a misnomer for all of these benign ones, why don't we call it a nevus with architectural disorder, and then you grade the atypia. But of course, this is too long of a name, and dysplastic nevus, which could be nicely shortened to DN, stuck for good. So we're kind of stuck with that name. So what's the problem with grading? Well, the problem with grading is that if you have one that's mild and you have one that's moderate and you have one that's severe, the natural interpretation is that one progresses to the other. And so, you know, all of my residents that come through now, if they were to see that, they would assume that these benign lesions are somewhat pre-malignant. But if you have a patient that comes in with 30 of these and you get a dysplastic nevus with mild atypia, you don't treat it like an actinic keratosis and remove them all, right? And so our practice doesn't match the words that are being used. And then there's a lot of confusion about the moderate subset, because moderate includes a lot of different things, both lesions with uncertainty for various reasons that are not necessarily true atypia, or, you know, truly the first early step toward, you know, toward melanoma. So, and then I will tell you, over the years, after seeing many, many, many slides from all over the place, what the threshold people have to put something in moderate varies widely. So generally, how should you approach this? What is mild atypia? It's generally insignificant. It refers to a benign nevus with a shared architecture. So we probably shouldn't even use this word, and I haven't used it for years. I top line it a compound nevus or a junctional nevus. And I might acknowledge that it shares the architecture in a note, but I say that there's no significant atypia, because what is mild? If it's not significant, it's not significant. What is moderate dysplasia? You know, there's all these papers. Should we treat moderates? You know, should we ignore moderates? As if moderate is a thing. The problem that I want you to understand is that it is not a true entity that's defined. It includes things like, the majority of them include pathologist uncertainty, right? Did you train somewhere where everything's called moderate? Is it specimen related? Is it a partial biopsy? So you cannot evaluate circumscription, symmetry, and you're just going to be more careful than not because you don't see those features. Are you a nervous Nelly, or are you cavalier to determine whether you think everything is moderate or everything is not moderate? Are there secondary changes? Is this thing inflamed? Is it irritated, making you uncertain? These things are not true atypia necessarily, but they are contributing to the pathologist's uncertainty, and therefore they put it in this category. You have to interpret melanocyte morphology. Spitz lesions have kind of non-typical melanocytes. You have pagetoid cells. Pagetoid meaning large kind of grayish cells, not cells that skip upward. So unfortunately, things sometimes have multiple names. Is it a special site nevus? You know, sometimes these can make something look worse, but actually in that context, they are normal. But there is a subset in this moderate category that is probably a low grade or early step toward melanoma. What is severe atypia? Severe atypia should be reserved for things that are likely evolving towards melanoma, or where, you know, a set of pathologists might consider it early melanoma arising in a nevus, or, you know, an atypical nevus with areas that resemble melanoma. There is a lot of inter-observer variability here, but if you think about the possibility of melanoma arising in this nevus, then you are in this category. So in 2018, this is relatively fresh off the presses, the WHO made new recommendations, and they finally recommend against using the term mildly dysplastic nevus, because it is not associated with increased risk of melanomas. We do not think these are premalignant lesions, and they are very common in the population. They are almost every flat, dark acquired nevus in an adult. And then they recommend using low-grade or high-grade dysplasia. Well, that may be hard to change just because obviously renaming things is very hard, but they're probably talking about, you know, that true atypia in the moderate category versus that getting very close to melanoma in the severe category. So just remember, there's two separate things we're talking about. And now that we have molecular studies, we're seeing that these truly are intermediate lesions. When they're atypical, they are heading towards melanoma by adopting new mutations, okay? And so these are truly what should be referred to as a dysplastic nevus. Now, all that said, let's put everything in the context of the big picture. So if you look at a meta-analysis of nevi associated with melanoma, the big picture is that melanoma actually occurs in association with this dysplastic nevus architecture less commonly than it arises in a common nevus, a congenital nevus, or Spitz nevus, etc. Meaning that melanomas that arise in nevi more often arise in just completely banal nevi or congenital nevi, other types of nevi, rather than in the DN architecture nevi. Okay, so the DN architecture nevi are the ones that got the name DN, but all these other nevi can be atypical and progress to melanoma also, and they do so more frequently. So keep that in mind. Additionally, the majority of melanomas, 70% of melanomas, arise de novo, so from like a single cell in the epidermis, not in a nevus, okay? That is your big picture look. And I'm done with my dysplastic nevus soap dish. So let's move on to a nevus with a completely different architecture. Now you have pigmented dendritic or spindled melanocytes within the dermis. These melanocytes with pigment in the dermis give you the look when light shines through of the blue color. This is a blue nevus, okay? So these little melanocytes have little dendritic processes, little legs that come off, and you can see the pigment come off. Whereas this round guy is probably a melanophage, a histiocyte with melanin in it, which you'll always have a lot of among the blue nevi. But you see these little legs coming off with the melanin? Those are dendritic melanocytes. And if you have a collection of them, you have a blue nevus. Sometimes you have these very cellular ones with dumbbell shapes. It's a cellular blue nevus. Sometimes it's very hard to see the cytology of these. Sometimes you even have to bleach it if you're worried you're looking at a bad nevus, but they're heavily pigmented usually, although you can have a quote unquote white nevus, which is composed of these cells but has no pigment. So here's another look at these spindled and dendritic melanocytes. A more sclerotic blue nevus is when you have more of this collagen change, and it's a less cellular nevus. So a lot of fibrosis and sclerosis, and then you have less spindled melanocytes. but you can see the melanin color out here. Look, you can even have collagen trapping, so you might think about a dermatofibroma from far away, and then you come in and you're like, no, this is melanin. These are dendritic melanocytes. I'm looking at a blue nevus. Okay, here they are up close, these little dendritic processes. So what's a Spitz nevus? Well, Spitz nevus is kind of a messy topic right now that will be evolving in the next few years. But generally, to be a nevus, it has to be small, symmetrical, and circumscribed, right? Same rules apply. But these melanocytes are more spindled and larger in the epidermis, or they can be very round and polygonal in the dermis. So epidermis, spindle, dermis, round, plump cells. And then in a Spitz nevus, you might have melanocytes above the DEJ. You can't have a lot, you can have a few. Obviously, that threshold is completely different from person to person, but generally the rule is a few is okay, a lot is not okay. A few towards the middle is better than towards the edge. Elongated nest, camino bodies, probably basement membrane material that's found in clumps in the epidermis. They can be heavily pigmented. These are referred to as pigmented spindle cell nevus of Reed. And then in the dermal Spitz, these round epithelioid melanocytes that have abundant cytoplasm. Of course, there's other looks for Spitz too. Almost everything that looks weird gets put in this category, but molecular studies are helping to sort out the different types. So now you can see in the Spitz nevus that your nests are not perfectly round like they were with the banal nevus. And when you go in, you can see part of the reason they're not perfectly round is because the melanocytes are not perfectly round. They're a little bit elongated and spindled. And remember, they're going to travel in and out like a ribbon of your through the epidermis, and when you cut it 2D, some of the melanocytes will be in aggregates coming towards you in cross section, some of them will be side to side, so the orientation may change. Here you see you have a few melanocytes above your DEJ, even in your interpapillary plates, so now the rules don't apply, and if you want to be strict with certain things, you might call this atypical, but in the context of a Spitz nevus, this is normal. Again, another Spitz nevus. Now you can see your nests are more elongated because your melanocytes are more spindled. A few melanocytes above the DEJ again. But this lesion was small, well circumscribed, symmetrical, and in a child, and otherwise determined that it was benign. Okay? See, here's your few melanocytes above the DEJ. So, as a side-by-side comparison, again, because I love those, round melanocytes make round nests, more lentiginous, causing bridging and tissue reaction with the lamellar fibroplasia, some pigment dropout. This is that architecture in the acquired nevi or in dysplastic nevi. Spindled, more elongated nests, allowing for a few cells above. This is your Spitz nevus. Okay? Now, well, when is an atypical Spitz nevus? You can see this doesn't have well-defined nests, right? And you can't see it very well circumscribed. It's hard to even see where these melanocytes are. But this was small and it was on a child. When you looked inward, you said, oh, these melanocytes are a little bit spindled, but they're not well formed or well nested, and there's a few more cells above. This would be an atypical Spitz nevus. And your threshold for getting towards a melanoma would be determined by how many cells are above, how big is it, how well circumscribed is how much confluence you have versus if you start to form nests. So a lot of these are just a degree question, in which case there's inter-observer variability. Let's look at a dermal Spitz nevus. Here, your melanocytes are more plump. You have more plump pink cytoplasm than a regular melanocyte. It's easier for me to show you side to side. So here you see these uniform little cells, and these are the plumper ones on top with their amount of cytoplasm. You can see these are a little plumper with more cytoplasm. Okay, so that's a Spitzy look when it's dermal. Now, a lot of work, especially at UCSF, has been done where they've been looking at individual mutations when they've sequenced these quote unquote Spitzy type of nevi, because sometimes they're spindled, sometimes they're round, they have different architectures, and they found that some of them have various mutations that actually correlate with kind of consistent architectural patterns. So one of the papers that came out were when you have filigree-like reedy ridges, lobulated nests, rosette-like structures, where they kind of line up, the nuclei line up on the outside, they tend to be associated with an N-trek fusion mutation, okay? Remember, our normal nevi might have a BRAF mutation. Here, they describe some of the features if you have an ALK mutation versus an N-trek mutation. So we're starting to be able to sort out these funny, spitzy nevi/tumors. We can start to see, can we further subcategorize them based on molecular, genetic data, and then maybe follow their behavior and get a better understanding of these things. All right, enough of that. Let's move on to recurrent nevi. Now, recurrent nevi, the problem is they don't follow the rules. You can be very asymmetrical. You can have runs of single cells, variable cytologic atypia, melanocytes above the DEJ. So the only thing that can tell you that it's recurrent is you see a scar in the dermis, and maybe you see benign nevus around the edges of it, okay? But anytime you see something very atypical in the epidermis, if you see a scar in the dermis, you need to hold on and back up a minute before you call something a melanoma. So here, look, you have these single melanocytes along the DEJ, random nests, no good reedy ridge pattern, a few cells above, but you have a scar. So you have to be careful. See single cells trickling off. For all intents and purposes, this fits the bill for an early melanoma in situ, but that scar tells you you got to be careful. Here's another one, nested, single cells, cells above. These nests don't look too bad, but if you have, the original biopsy and you say, oh, this was a perfectly good intradermal nevus, and all of this is confined to within the boundaries of the scar, then you can be fairly confident you have a recurrent melanocytic nevus. Now, if these things go to the edges of the re-excision or the re-biopsy, I often tell people that it goes there because, only the history of the original nevus or reviewing the original pathology and knowing it was benign tells you that that is benign. So if it extends to the edges and you don't know that it doesn't clear the scar, then you might have to go back and re-excise it. All right. What is this entity, atypical intraepidermal melanocytic proliferation, AIMP? Well, remember, 70% of melanomas arise de novo, not in a nevus, okay? So before there's a melanoma, there's just a proliferation of atypical melanocytes. So you're not going to call it an atypical nevus because it never was a nevus. So that's what these AIMs are. They are the atypical proliferation before you get to melanoma in the lesions that never started as a nevus. So here's an example. Here's an epidermis, and if you can see, you have these enlarged single melanocytes along the DEJ. They're kind of prominent, they're a little too close together, and there might be one or two above the DEJ. So you're like, this is a little bit suspicious. Maybe it's bad sun damage that's making you have these funny looking melanocytes, but they're single right now. You can't call it anything more than an increased number of single, slightly atypical melanocytes. Where will that go? Who knows? It may become nothing in that patient's lifetime, or it may move forward, but it's worth noting. Here's a little up close. Cells are kind of, a little bit large, worth keeping an eye on. Now, you can see that in this area, there's more cells, okay? They're now closer together. There's more cells above. Everyone see these single melanocytes in a higher concentration. This is definitely an atypical melanocytic proliferation, atypical intraepidermal melanocytic proliferation. It is not melanoma yet because it may not be large enough or you may not have enough cells above, but it's definitely heading there. Why don't we call these potential pre-melanomas early melanomas? Well, there are clinical implications. A person may have their insurance carry the code of melanoma for the rest of their lives, and it may be difficult for them to get insurance. For that reason, you don't want to call a melanoma until they have it. If this is an 80-year-old person, how do you know that during the course of their life this would have become melanoma? You don't know that. You have inflammation that can clear things, right? You have, your body has many reparative processes that can suppress or, clear things. So until it is melanoma, we do not call it melanoma. This is an atypical intraepidermal melanocytic proliferation. On the other hand, now look at this. Now you have confluent melanocytes. They're almost completely taking over the DEJ, pushing out all those keratinocytes. You have almost confluence of melanocytes above the DEJ. This would cross most people's threshold for melanoma in situ, okay? And that's just a matter, again, of how many. So different people's thresholds are different. On the last one, someone might have called it, you know, early melanoma versus atypical intraepidermal melanocytic proliferation could be evolving melanoma. That would be the distinction in the name. This, most people would agree, you're at lentigo maligna melanoma. Lentigo maligna meaning a lentiginous proliferation. Okay, so malignant melanoma has a lot of these atypical features. It's asymmetrical, melanocytes above the DEJ, atypical melanocytes, increased solitary melanocytes over nested ones, meaning this lentiginous spread, poor circumscription, large size. So this is a silhouette of a lesion far away. This is quite large. This one's over a centimeter, likely. And look, there's a nevus here. Actually a very benign, banal looking nevus with nests at the tips of the rete. And, you know, interpapillary plates are clean, small nests in the dermis. So it looks, for all intents and purposes, like a compound nevus. But then on the other side of the lesion, this is what your melanocytes look like. They look awful. So you can see here that this melanoma has arisen in a nevus. And you have these atypical cells that are above the DEJ. And then look in the dermis, you have some of these big cells that are the melanoma that are invading, and some of these little melanocytes, which are probably remnants of that original nevus. See, these little guys. This is a melanoma that did not arise in a nevus. You can see nothing here reminds you of the architecture of a nevus. You just have random nests, single cells, nests of melanocytes all throughout the epidermis. Melanoma. These ones, single cells, cells above. Sometimes they're hard to see, but you can see that your desmosome pattern and your basal layer are disrupted, and that should catch your eye. This is obvious, right? Obvious melanomas are obvious. Very atypical, nests in the epidermis, nests throughout. This thing never started as a nevus. Cells above the DEJ, atypical melanocytes. Obvious. All right. So this is just an introduction to melanocytic proliferations. There's obviously much more to it, but it's just like kind of a general understanding and probably sufficient for your testing purposes. Summary points. Solo lentigo, not melanocytic. A banal nevus, you have monomorphous melanocytes and it can be junctional, that means only in the epidermis, compound in the epidermis and dermis, or purely intradermal. You can also have congenital architecture where it matures and the single cells extend down along annexal structures. Dysplastic nevus is a term that's used variably. I feel that it should only be applied to nevus with that architectural pattern of the bridging lamellar fibroplasia shouldering with significant atypia, where you have atypical melanocytes, cells above the DEJ, cells in the interpapillary plates, where you're worried it can move to melanoma. The other ones with the shared architecture and no significant atypia should not fall under the term dysplastic nevus. Spitzoid lesions, you have large spindled melanocytes in the epidermis or large epithelioid melanocytes in the dermis, and that's kind of a broad summary of things that fall under the spitzoid category. Blue nevus is when you have pigmented dendritic melanocytes in the dermis. What is a melanocytosis like a Mongolian spot or a nevus of Ito? Well, it's going to be very scattered dendritic pigmented melanocytes through the dermis. It almost looks like normal skin, so they won't be all grouped together like in a blue nevus, but they'll be scattered throughout the dermis. Melanoma has atypical melanocytes, cells above DEJ, asymmetrical, and it can begin in any type of nevus, not just the dysplastic nevus, and it can arise most commonly de novo. And that's it.